Welcome everybody. My talk, as you see, about the hemodynamic and cardiovascular support in critically ill COVID-19 patient. As you know, the respiratory support take maybe 60 or 70% more for the attendance of the physician managing the critically ill COVID patient. So this is some focus on the hemodynamics and the cardiovascular support. Now, the overview of these lectures, we have to talk about some introduction, shock and myocardial injury in COVID-19 patients, fluid therapy and the blood transfusions, how to use the inotropes and which vasopressor is okay for COVID critically ill patients, what is the hemodynamics changes, and then conclusion. We'll start with the beginning. What is the secret of success? According to Albert Einstein, the secret of success, know where to find the information and how to use it. That is the secret of success. Actually, in medicine, we have thousands of information every day. And in COVID especially, we have a lot of emails, WhatsApp message, guidelines, local policies. So you have a lot of information. How to use it in medicine? You strategies. In my lecture, I will focus in 3 sources. The first one from the surviving sepsis campaigns, and this is published in March 2020. And the second one from China about the management of critically ill COVID patients. And this is written more simple than the surviving sepsis campaigns guidelines. And actually it is more practical. And the third source from the WHO, which is published in 27 of May, clinical management of COVID-19 patients. And the important in WHO guide that it is for low countries with limited resources. So it is not so sophisticated guidelines, and it can be used and applied easily in the most of the countries. Now, what is the time course of COVID patients? We have 3 stages, stage 1, 2, and 3. Stage 1 due to the early infections, then pulmonary, then hyperinflammations. The viral response phase takes stage 1 and stage 2, and after that, the host inflammatory phase may be hyperinflammation by the end of the stage 3. And in each stage, we have signs and symptoms, which is characteristic for this one. Fever, headache, or non-specific symptoms and signs, and the cough and diarrhea. This is in the first stage. Second stage, pulmonary signs and symptoms, shortness of breath, hypoxemia, abnormal X-ray and chest X-ray. After that, the patient may develop shock, adult respiratory distress syndrome, and increased inflammatory markers. And your options, according to the situation, you may use antiviral, antimalarial, you may use plasma transfusions, steroids. In any way, we are talking now about the critically ill patient, usually in stage 2B or stage 3. So this is our target or talk today. Now we will talk about the hemodynamics changes in critically ill patients. We have main 4 issues: COVID cardiac injuries, hypovolemia, right ventricular failure, and vasoplegia. COVID injury may be treated with catecholamine, vasopressors, anti-inflammatory, ECE inhibitors, ARP, or anticoagulants. Hypovolemia may be treated with crystalloids, albumin, and blood transfusion if the patient is anemic. Right ventricular failure, you may need nor-epi, optimization of oxygenation, the optimal PEEP, you may need prone position, nitric oxide, or even ECMO. Vasoplegia, this is a big problem, not responding for the catecholamines for nor-epi or epi, so you may use vasopressin. Celepressin is almost the same, but it's more specific, acting on the V receptors too, so it is less side effect than vasopressin. Angiotensin 2 can be used as well. Steroids, methylene blue is suggested in case of vasoplegia. treatment of acidosis and anemia, because both of them may cause vasoplasia and query vitamin C. Of course, we will not mention all, but just it is for simple understanding. This is the 4 categories which we are dealing in patient with hemodynamic instability. As you know, there is cytokine storms in patient with COVID. And actually, it is not limited to the COVID virus. It is most of the viral infection may cause cardiac inflammation. And according to the severity of or the release of the cytokines, either interleukins or CSF or necrotizing factors, anyway, you have stages. The first stage, viral myocarditis, autoimmune myocarditis, then dilated cardiomyopathy. So this can occur with any severe viral infections in specific virus. And actually, this is not a new issue. Since more than about 28 years, these articles summarize the effect of virus on the heart. And they list here a lot of virus which may cause heart damage, and the clinical presentation, which can range from no clinical manifestations or some arrhythmia, tachycardia, patient may have heart block, gallop, this heart failure, pericardial rub, and circulatory collapse. So the effect of virus in heart is something old, and we should understand it and to know how to deal with our patients. It is very common to have increase of troponin in COVID-19 patients, but actually troponin can be increased in acute respiratory infection and the patient with pneumonia as well. And the more severity of the infection or more severity of the pneumonia, the higher level of troponin. But troponin can increase as well in type 1 myocardial infarctions, these plaque ruptures, which can be happened easily during acute infections, or if the patient in shock and there is impairment of oxygen supply and increased oxygen demand, this may cause type 2 myocardial infarction. So that's why we have high troponin in critically ill COVID patients. Actually, if the patient has high troponin with history of the cardiac disease or cardiovascular disease, the mortality is very high, is around 70%. If the patient don't have cardiac disease and the troponin is high, the mortality is 37%. And if the troponin is normal with cardiovascular abnormality, mortality is 13%. If there is no cardiovascular disease, normal troponin, the mortality is 7% only. So in short, cardiovascular disease plus troponin carries very high mortality. Also, the cardiovascular failure is the second cause of death after respiratory distress syndrome and respiratory failure. And you can see acute myocardial injury is responsible about 30% of the death. Acute heart failure is responsible about 19% of the death, multi-organ failure 9%, and shock 6%. So the myocardial injury may cause significant mortality as well. How the cardiac injury happen in COVID patients? We have different mechanisms. Due to the release of the cytokines, we have oxidative stress, which is causing microangiopathy and vasculitis-like mechanism, and this characterized by high D dimer. Second mechanism is immune-mediated injury, and this may cause myocarditis, but myocarditis actually is a clinical diagnosis, and it should be proved by biopsy, myocardial biopsy. So just it is clinically suspected patient if exclusion of the other factors, this is the immune-mediated myocarditis. The third injury by endothelial dysfunctions, and this cause actual myocardial infarctions, and as we explained before, it may cause type 1 myocardial infarction or type 2 MI. And this is common in patients with cardiac disease. Another problem, arrhythmia may happen, and also because of the hypercoagulability state, we may have DVT and pulmonary embolism. So it is around 5 mechanisms causing the injury or increase of troponin in COVID patients. It is very common the patient complicated with sepsis and septic shock, so he may develop the septic cardiomyopathy, and we have down regulations of the beta receptors, myofibral dysfunctions, so poor contractility, and usually there is dilated heart, left ventricle, myocardial depressant factors due to the cytokines and inflammatory mediator release, microcirculatory dysfunctions, usually due to the local hypoxemia, mitochondrial dysfunctions. The patient may have anaerobic metabolism and some disorders in the calcium handling. So the patient may have COVID injury and may complicated with septic cardiomyopathy. The risk factor of shock in COVID patient, old age, diabetes, cardiovascular disease, hypertension, or the lymphocytes count is low or high D-dimer level. So if you find one or more of these risk factors, expect higher incidence of shock. Cardiovascular disease and the drug therapy, in addition to the old age, more than 65 years, this is the risk factors of higher mortality. Coronary artery disease, congestive heart failure, arrhythmia, COPD, and current smoker. And also, if the patient has angiotensin receptors blocker, it may be higher incidence of mortality. But with EC inhibitors, no problem. Female patient, no problem. And statin, no problem. Maybe statin cardioprotective. In short, patient with old age, cardiovascular disease, and respiratory disease, higher cardiovascular mortality in COVID. Now we come to the fluid therapy and the blood transfusions. Usual controversy regarding the fluid therapy. What is the optimal composition, or what, in other words, what is the good fluid to give, colloid or crystalloid? Which crystalloid you have to use? How much volume is needed? How to assess the fluid responsiveness, and there is place for albumin or no in resuscitation or COVID patient, and when the blood may need blood transfusion. Stewardship, as what do you know? What does it mean? What is in language stewardship means? In Oxford Dictionary, it means supervising or taking care of something. But in medicine, it is different. You have coordinated strategy for optimal and limited use of antibiotic, opioid, and intravenous fluids. And Dr. Kafafi explained for us the optimal and limited use of opioids in patients with chronic pain. So now we are going for optimal and limited use of intravenous fluids. How we can do that? First, you have to use the fluids as a medication. To a specific type, what is the type of fluids you are going to use? How much I will give you for our patient, for example, 4 ml per kg over 10 minutes. What is your objective? What is your target? So you need to reduce the heart rate, MAB is okay, and improve the microcirculations. What is the limits if the patient has, for example, higher CVP or overloaded or extra vascular lung water? So you have to decide the type, rate, objectives, and the limit. And we have what is named rule of force in fluid therapy. You have to ask yourself 4 questions. When you will start the fluid and when to stop it, when to start removing the fluid from the patient, and when to stop removing the fluid from the patient. What is the indication? It is for resuscitation, you may need higher volume. It is just for maintenance. It is for replacement, for loss. Patient for septic peritonitis, for example, he needs some good replacement, and it is given for nutrition or no. Third point, you have again to deal with the fluid as a drug. Is it how much dose? What is the duration? And again, when you stop or de-escalations. 4 stages. Patient with shock, usually you start with resuscitation, then optimization, then stabilization, then evacuation, and this is named Rose concept or Rose approach, and we will explain it very soon. The last point, you may have 4 hits in your patient. Initial insult, like COVID with sepsis, patient need higher volume of fluids. After that, the patient may have reperfusion injury. Again, you have to limit the fluid resuscitation. Patient after that may have fluid accumulation and increased permeability. Later on, during the de-resuscitation, the patient may develop hypoperfusion. So it is 4 questions, 4 indications, 4 Ds, 4 stations, and 4 hits. Now I will explain the ROSE concept. What is ROSE concept? It is 4 stages. First stage is a minute. During resuscitation of the patient, you need high volume of fluids to reach your target, your MAP, reducing heart rate, or cleaning serum lactate. After hours, now you have to optimize the organ perfusion and organ support, especially the brain and the kidney. And this take few hours after resuscitation. Days after that, the patient now stabilized in ICU. You have to keep him in the negative balance, either by diuretics or by hemodialysis. And within weeks, you have to evacuate your patient. So this is the ROSE concept in all types of shock, not in COVID patient only. Resuscitation, optimization, stabilization, then evacuation. Now, how to assess the fluids and its side effect? You already decide to give fluids, and is this fluid effective or no? And what is the side effect? You are monitoring the oxygenation of the patient, improving of lactic acidosis, improving oxygenation, decrease PCO2 gap, and the patient cardiac output increased or low. You can use the capillary refilling or mottling, and it is possible to use cardiac output monitoring as well. And did the cardiac preload increase, the patient may develop the gallop. So you may need to use echo to assess your patient. Side effect, increased lung edema, so you have poor oxygenation and increased lung water. Hemodilution, hematocrit is dropping without significant loss of blood because of the fluid over resuscitation. Did right ventricular deteriorate? You should assess with echo or CVP. And the patient whose intra-abdominal pressure may increase with extra fluid loss, with extra fluid resuscitation, sorry. So in general, you have to decide if this patient in adequate fluid resuscitation or volume unresponsiveness. Because some patient with unresponding to the fluid, you may give fluids more, and this, of course, may have side effects. So you have to differentiate between adequate fluid resuscitation and the fluid unresponsiveness. How to assess the fluid response? According to the Surviving Sepsis campaign, you should use dynamic, not static parameters like skin temperature, capillary refilling time, and serum lactate measurement. And as you see, this is something very simple, can be done in most of the centers, even with limited resources. We will compare here between the capillary refilling and the lactate clearance. After about 28 days, they found that the mortality is very close together. Lactate is around 41%, peripheral perfusion by capillary refilling is around 38%. So if you are using capillary refilling as a target for fluid resuscitations, it is very close to lactate if you don't have lactate available, or may be difficult to do it very frequently in your hospital. Dynamic versus static assessment of fluid responsiveness. Usually the dynamic is much better than the static. So it is the current recommendations, all type of shock, all the patient receiving fluid resuscitation, you should use dynamic assessment, not static assessment. So now, which type of fluid you are using? You use crystalloids, not colloids, and ringer lactate is better than normal saline. And during acute resuscitations, there is no place for starch or gelatin, dextrans, or albumin. So you will focus now about the ringer lactate. So for WHO interim guidance, they recommended smaller volume. If you remember, when you are resuscitating this patient with sepsis, according to the Surviving Sepsis campaign guidelines, you are giving 30 ml per kg. So in 70 kilo patient, you may use initially 2 liters. Here is conservative management, because COVID patient may come not in shock, not in septic shock. There may be some cardiac dysfunctions. This is a cause of hypotension. Most of the patient coming initially is not in cardiovascular shock. So they may need a small volume of the fluids, 250 to 500 ml, and they didn't WHO didn't specify the type of crystalloids, either ringer lactate or normal saline, and to be given over about 15 to 30 minutes. If you have a pediatric patient, it is 10 to 20 ml per kg. Also, this either ringer lactate or normal saline given over half an hour or 1 hour. And the usual recommendation for conservative management, because patient with hypoxic respiratory failure may worse with increasing fluid load. So you again, conservative fluid, and I think this is a good approach. Start with a small volume and assess your patient in short time. Why we are using the balanced crystalloids, this means ringer lactase or plasma light if it is available, because usually this lower rate of death from any cause or renal dysfunctions. And you can see here, most of the patients who received the balanced crystalloids is doing much better than normal saline, and all subgroup of patients, cardiac patient, trauma, surgical, maybe the patient with neurogenic or traumatic brain injury, it is maybe better to use normal saline. In short, in most types of shock, ringer lactate is doing better than normal saline. Is any place for colloids? According to the Cochrane Library, the starch, dextran, albumin, gelatin, little or no difference in mortality. Again, in most types of shock or surgical patient as well. But in COVID patient, it is different. It is recommended to give albumin to maintain it around 30 grams per liter, and using albumin 20% to not 5%, to give a smaller volume and to correct the hypoalbuminemia with smaller volume of fluids. And you may need to use diuretics as well, loop diuretics, thiazides plus spironolactone, to minimize the effect of fluids overload, and consider ultrafiltration early, even if the patient don't have acute kidney injury. If the patient is overloaded, it is considered ultrafiltration early, this to minimize the effect of overfluid loads on the lung, especially in patients with respiratory distress syndrome. And there is another recommendation also for albumin, because albumin, as you know, it is a good buffer, and as well it is a stabilizer and delivers the drugs. Patient with hypoalbuminemia may be impairment of the carrier of the antiviral medication. So there is a good recommendation to use albumin in your COVID critically ill patient. Generally, the fluid overloads have a lot of systemic effect: respiratory, hepatic, gastrointestinal, abdominal wall problems, renal, cardiovascular, and CNS problem. We will focus in the cardiovascular problem in patient receiving a lot of fluids, myocardial edema, impaired contractility, may have diastolic dysfunction, decrease in the stroke volume and the cardiac output secondary to the impaired contractility. Conduction disturbance may be happen, pericardial effusion, and increase the pulmonary occlusion pressure. So as you see, all the articles or all the resources focus in the conservative management because of its bad effects. Again, this is the rules of four questions, 4 indications, 4 Ds, 4 stages, and 4 hits to manage therapy in all types of shock. Now we will come to the blood and the blood products. The 3 resources that I mentioned, either from China or Surviving Sepsis Campaign or WHO, nobody mentioned something about the blood and the blood products. So you may follow your local protocols or the Surviving Sepsis Campaign that's published in 2016, or you may follow conservative strategy. But usually in critically ill patient, you have to consider the following: the relationship between oxygen delivery and oxygen. Normally, if you have dropped from hemoglobin from 13 to 7 or 8, the oxygen delivery still can match the oxygen consumption. But below 7, we will have critical oxygen delivery. It may be 6.5 or 6. It is not clear actually how much. But below 7, you have critical oxygen delivery. But in critical illness and in sepsis, there is shift of this curve to the right, and the critical oxygen delivery will be higher. You can see maybe hemoglobin 8 or 9, the critical oxygen delivery. So during hemodilution, you are giving fluids and reducing the mass of RBCs, there is increased total oxygen demand, and oxygen delivery or critical oxygen delivery is met at higher values. So you should consider this during managing the critically ill patient in general and the COVID patient as well. The other problem from anemia, it is well known to cause normovolemic hemodilution and decrease systemic vascular resistance. So this may be good in some patients, but patient with sepsis, systemic vascular resistance is already low. So if the patient is anemic, this may reduce the vascular resistance more. And the other important issue, it is vasoplegia. You are giving nor-epi or epi, and the patient is not responding because of anemia and its effect in the blood vessels causing vasoplegia. Generally, in ICU, you have to optimize the blood mass with the proper blood transfusion according to your policies, minimize the blood loss by proper hemostasis, optimize the tolerance of anemia by maintaining normovolemia and maintaining good oxygenation. So this is the 3 strategies to minimize the blood transfusion. Now we will come to the first point, the vasoactive drugs and inotropic support. The current recommendation to use fluids and nor-epi to maintain MAP between 60 to 65. And nor-epi is always the first drug of choice. If nor-epi is not available, you may use epinephrine or vasopressin. Don't use dopamine if nor-epi is available. So nor-epi is the first drug. Dopamine, as you know, may cause tachyarrhythmia, and it is used in patients with tendency for bradyarrhythmia. If the patient is not responding for nor-epi, you can add vasopressin. If the patient still has cardiac dysfunctions or hyperperfusion, dobutamine can be added. Usually in patients with low ejection fraction, dobutamine is a good choice. In refractory shock, low-dose corticosteroids can be used. Actually, this guidelines was published in 28th of March before the recovery trials about the use of dexamethasone. But dexamethasone is used mainly as anti-inflammatory, not to support the cardiovascular system. So corticosteroids, the same, almost like septic patient. You start to give fluids, patient not responding, you are giving nor-epi, not responding, so you have corticosteroids or steroids for to support the circulation. Now we will come again back to the WHO DREAM guidance. They recommend for MAP 65, but the point here to use the nor-epi during the IV fluid. Don't wait for fluid responding or not responding. You can use it a little bit earlier. And nor-epi again is the first drug of choice. So there is no changes or no difference between surviving sepsis campaign and WHO. In many patients, it may be difficult to find central line or no time to do central or even no resources to put central line. So it is you can use large vein with close monitoring, and the vasopressor can be used intraosseous as well. Maybe this is in pediatric patients or a small baby, but there is good evidence to use the vasopressor in the large vein with close monitoring to avoid the extravasation or tissue necrosis. And in pediatric patient as well, it can use more dilution of the nor-epi or epi to support the circulation until to get a central line. Again, all these recommendations to give you more space and more chances during the management of your patients. And if the central line is difficult or not possible, you can use epinephrine or non-epinephrine in peripheral lines. Why we are using nor-epi in most of our patients? actually it has strong alpha stimulation and weak beta stimulation. With beta stimulation, increase the contractility. Alpha stimulation, increase MAB, increase coronary perfusion, and increase afterload. This increase of afterload increase the contractility within about 10 to 15 minutes, and this is named NREB effect. So the NREB effect means increase the contractility secondary to the increase afterload or systemic vascular resistance. And the end result, this increase the stroke volume and increase cardiac output. That's why we like nor-epi in most types of shock as first line of therapy. We have to talk again about the vasoplegia, this poor response for catecholamines, and it is common in all types of shock, especially with inflammation and the presence of nitric oxide and during reperfusion and ischemia reperfusion as well. There is a lot of talk about vasoplegia and how to treat this. May need separate lectures, but the most common causes the acidosis, anemia, and the presence of ischemia reperfusion injury, especially also in patients after cardiac bypass as well. We have a new term, what is named decatecholamine. This to minimize the use of catecholamines, and this again because the problem of vasoplegia, because the beta stimulant in general increase the pre-inflammatory cytokines. So there is many trials to use vasopressin with beta blockers to reduce the inflammatory response, especially in patients with inflammatory response syndrome and septic shock. And as you know, levosimendan now is used in many patients. I will talk about levosimendan very soon now. The last point in my lecture is the hemodynamics in critically ill patient. This is the normal heart-lung interactions. With inspiration and increased intrapleural pressure and transpulmonary pressure, we have reduction in the right ventricular preload and increase the right ventricular afterload. This leads to the reduction of the right ventricular stroke volume. In the left side, we have reduction in the left ventricular afterload and increase the preload. So there is some increase in the left ventricular stroke volume. This during inspiration. During expiration, the reverse happens. Reduction in the left ventricular preload and decrease in the stroke volume. This usually in normal patient without significant hemodynamic problems can be tolerated well. Maybe patient needs some fluids or very minimal dose of inotropes, but this is happening if you initiate the mechanical ventilation. Of course, in patient with respiratory distress syndrome and the patient with severe lung hypoxemia, it is different changes. For example, if you, like in COVID patient, you may need high beep. High beep 15, reduce both left ventricular volume and the pressure and increase the right ventricular volume and the pressure. And you can see what is named D-shaped right ventricle with displacement of the septum to the left side. And in some situations, the right ventricle pressure may be equal or even exceed the left ventricles in patients with severe pulmonary hypertension. The condition may be more worse if the patient develops auto-beep, because auto-beep leads to the hemodynamic instability, and you may, patient is hypotensive, you may give him more fluid because you may think the patient is hypovolemic, you are giving more fluids, and you are using unnecessary vasopressor therapy. So you have to detect auto-beep early and to release it to avoid improper fluid management. We are using the prone position to improve the oxygenation, but also it may improve the cardiovascular parameters. You can see here the effect on the right atrium, the effect in the pulmonary vascular resistance, the effect on the cardiac index. Right atrial, it will increase the pressure because of the prone position, increase intrathoracic pressure. Because improvement in the oxygenation with prone position, the pulmonary vascular resistance will be less. Cardiac index may increase in patient with preload reserve. That means if the patient is relatively hypovolemic or he needs some fluids, he will respond in prone position by increasing the cardiac index. So to summarize, the prone position have good beneficial effect on the oxygenation, but also may increase the right atrial pressure, reduce the vascular resistance, pulmonary vascular resistance, and it may increase the cardiac index. Now, it is very common now to use as dynamic indices to manage your patient. If the patient has significant pulse pressure variation, no. So no hemodynamic effect of mechanical ventilation. You need just to start no epi, no IV fluid, adjust your respiratory setting, limit the effect of hypercarbia, and maybe prone position. This if the patient don't have significant pulse pressure variation. But if there is significant variation, so hemodynamic effect of mechanical ventilation, the patient is either hypovolemic or have right ventricular overload. Hypovolemic with low CVP, if you are doing echo, the right ventricle is not dilated. If you assist IV with ultrasound, inferior vena cava will be small, and superior vena cava respiratory variation. So this patient need IV fluid, and you have to balance between the risk and benefits from IV fluid. Patient with right ventricular overload, high CVP, right ventricular dilated, the inferior vena cava is large, and there is no respiratory variation in the superior vena cava. And you have to manage the right ventricle by reducing both the preload and afterload. So this is the general management according to the PPV. The problem that the patient with respiratory distress syndrome may be not so accurate. You can see here in ARDS, pulse pressure variation, stroke volume variation, but seismography variability variation is not so accurate. Ultrasound draw sufficient data. In addition, it may be expensive, and it is not possible to assess all the patient with ultrasound. Again, the dynamic indices may be not accurate in patient ventilating with low tidal volume, and this is common in COVID with ARDS. Cardiac arrhythmia or calculation methods reduce their predictive value. Actually, it is very difficult situation how to assess the fluid responsiveness in patient with right ventricular dilatation, and if you don't have echo to measure the right ventricle pressure, volume, inferior vena cava, and superior vena cava. Anyway, if the patient has COVID pneumonia, this is defined by echo. 89% have left ventricular hyperdynamic, 41 right ventricular dilatation, dysfunctions in 27%, pulmonary hypertension in 16%. You can see the right ventricle is suffering more than the left ventricle in our patients. Again, in another study, they found that the right ventricular dilatation 31, hypokinesia 60%, 66%, tricuspid regurg in 21%, patient higher incidence of renal dysfunctions if they have right ventricular dysfunctions, and right ventricular dilatation is significantly associated with mortality. That's why we are focused in the right ventricle, not in the left ventricles in patients with COVID and respiratory distress syndrome. The right ventricles suffers also from the smooth muscles constriction, pulmonary vascular constriction by hypoxemia, hypercarbia, and increased endothelin 1. Microthrombi may happen, and the vessels compression by increasing lung volume, interstitial edema, and atelectasis. So how we can manage and how we can deal with these problems? This is the summary of right ventricular support during ventilation. Conservative fluids, we explained that. Nor-epi, also we told about that. Levosimendan is coming very soon. We have what is named right ventricle protective ventilation. Optimize the oxygenation, limit the increase in CO2, driving pressure less than 18 if possible. I know many of patients who may go to more than 25, but if possible, keep the driving pressure on the lower side. Beep without overdistension, prone position, nitric oxide, and ECMO. So this is the summary to support the right ventricle in our patients. Now, levosimendan have a lot of good effect. It causes vasodilatation and reduction of the right ventricular afterload. So it will improve the right ventricle ejection fraction and the cardiac output, also have cardioprotection effect, and reduce the right ventricle hypertrophy. At the same time, it causing coronary vasodilatation, so increase the right ventricular contractility and increase the capillary incidence. But it have many side effects: hypotension, hypokalemia, tachycardia, increase the risk of arrhythmia, either atrial fibrillation or ventricular tachycardia. Anyway, there is a good place of levosimendan in patients with pulmonary hypertension and right ventricular failure. So in conclusion, if you have a patient with hemodynamic instability, COVID critically ill patient with hemodynamic instability, we have these four: COVID cardiac injury, hypovolemia, right ventricle, and vasoplegia. And each one you have the specific management. And again, you have to focus in the right ventricle. And thank you very much for your attention, and hopefully you enjoyed the lecture.
Many thanks, Dr. Yasser, for your interesting lecture. And many thanks for continue updating and enriching our knowledge for management of critically ill patients. There are many questions coming from our colleagues. First of them, Dr. Isam Al-Ghami, he asked about which is more efficient to deal with arrhythmia. First choice is cardioversion or IV antiarrhythmic.
See, regarding talking always about the albumin is a controversy. You can see some persons supporting it, some not supporting it. But we have usually in COVID patient injury of the endothelium or glycocalyx. Glycocalyx can be protected with good albumin or normal or within normal albumin level. So, as it is mentioned in the questions, increased permeability to the endothelial damage. The main problem in endothelial damage is the damage of the glycocalyx. Glycocalyx can be protected with albumin perfusion. And as we mentioned, we have to give a smaller volume. We are using albumin 20%. And as we mentioned in another lectures before, albumin is important buffer of the body. If the patient has some acidosis, acidosis may cause vasoplegia as well, or no response for catecholamines. So normal albumin or near normal albumin is a good target in our patients.
We'll try for another question. Maybe easily. There are another question from Dr. Sama Al-Sukkari. She asked about the dose of dexamethasone and interleukin-6 in COVID-19.
Dexamethasone its role is well known since the publish of recovery trial maybe 2 weeks ago about the use of 6 milligram IV or PO once daily for 10 days. And after these trials, all the centers that we are on communication with them using this dexamethasone, not hydrocortisone. Before dexamethasone, we are using methylprednisolone 1 milligram per kg for 5 days. So if the only issue which corticosteroids has more anti-inflammatory effect and to counteract the cytokines storm, it's found that either methylprednisolone 1 milligram per kg for 5 days or hydrocortisone 6 milligram OD for 10 days, both of them are almost equal in the effect. Maybe later on we have the outcome from this methylprednisolone and dexamethasone from other studies, but it is not clear. If you already started hydrocortisone, no need for dexamethasone. If you started methylprednisolone, no need for dexamethasone. If you didn't use any one of them, you can start dexamethasone.
Another question by Dr. Ain Al-Marwa. Which stage of COVID-19 do you support the use of corticosteroids?
Which
stage of COVID-19 do you support the use of corticosteroids? Timing of corticosteroids.
Actually, maybe we don't have this slide here. There is in patient, I will tell you which stage you have to use steroids. One moment. If the patient start to be in pulmonary stage 2, this is the time to start the steroid here. If the patient just shortness of breath with just abnormal X-ray, it's okay. But start to be hypoxemic and he is going to the respiratory failure, or start to use BiPAP or high flow oxygen, it is the time to start the steroids. Before that, because you can see the host inflammation response is increasing with the time the patient has hyperinflammation response. So stage 1, stage 2A, there is no indication of steroids. 2B, stage 3, this is when to start the steroids. It's clear?
Okay, thanks, Dr. Yasser. Another question by Dr. Ayman. How can we manage persistent bradycardia with COVID-19? And actually, it is the same question of Dr. Basma Ghunaim.
Yeah, this is mentioned if the patient is tendency for bradycardia, dopamine should be used in additional to the epinephrine in this situation, or maybe adrenaline as well can be used. But the current guides from the surviving samples convene and WHO to use the dopamine in patient with tendency for bradycardia.
Okay.
He wrote there is a problem in his sound. He wrote
we may end the program tonight, and on your behalf, I would like to thank everybody attended tonight, and I would like to thank the great man, Mr. Dara Walsh. He is going to edit and make all videos available on YouTube tonight and maybe early tomorrow. So who miss the webinar will be able to catch it on the YouTube for us tomorrow morning. I would like to thank everybody attended tonight, panelists and attendees and the lecture, Dr. Yasser and Dr. Kafafi for the great scientific night. It is another successful day, and I would like to thank more than 250 candidates attended tonight, and thank you very much for our success. Thank you.
Okay, thank you.
Thank you, Dr. Warda, for distinguished moderation tonight, and very nice. And my apology to Prof. Hassan now, we couldn't catch his question tonight, and hopefully we'll talk to Dr. Yasser about that. Thank you.
Thank you.
Thank you very much.